everybody, welcome back for another week of our course. This week we'll be talking about health and political economy, or more specifically capitalism, socialism, communism, and different forms of healthcare under those different systems. Since the United States and many of the other Western countries that we spend a lot of time talking about in this course are capitalist nations, I think it's very important that we first understand what capitalism is before we jump into this analysis. So capitalism is a form of political economy. It is a political and economic system which focuses on profits and privatization. So under this kind of system, workers or people with jobs sell their time and their labor and their skills in exchange for wages. This could be hourly, this could be salary, but in essence, a person is selling their time and skills in exchange for money. Under this kind of system, we do see a lot of exploitation taking place. The exploitation of workers who we could call the proletariat, if we're using kind of a conflict theory or Marxist sort of lens or language here. The proletariat are those who don't own the means of production. So workers are typically not the people who own the businesses that they're working for, who own the factories that they're working in, or who own the perhaps the mines that they're working in, or the places where raw materials or resources are coming from. So we'll see a lot of exploitation of the proletariat, of the workers, of those who do not own the means of production under a capitalist kind of structure. The bourgeoisie are the wealthy, essentially, the people who control these different structures in society, who do own the means of production. A lot of the time we'll also hear this population called like the 1%, or just people who are much more wealthy than the average person, who may have a stake in things like politics and the economy in a way that the typical person does not. So within any country or nation that has a capitalist form of political economy, the healthcare industry and systems are going to be very directly affected by that. Capitalism is a system that focuses on profits, individualism, productivity, and efficiency. We'll often hear this phrase, pull yourself up by your bootstraps, this expectation that individuals will really be very self-sufficient in an economic way, but also taking individual responsibility for their health and well-being. And so these expectations, or this value of individualism under capitalism, this value of profits perhaps over people, of productivity and efficiency over quality of care, we do see, of course, some negative effects of these processes. I'd like you all to think to yourselves, what are some of the potential harms that are happening to our health, to our well-being as a society when our political economy is structured in a way that focuses more on making money through healthcare rather than the actual care to patients. We focus on productivity and efficiency and kind of getting people in and out like a revolving door in any kind of healthcare practitioner setting. What does that do for patients and for their health? Of course, we can also look further than just the way that our healthcare industry is structured under capitalism. We can look at how our well-being is directly affected by living in a society with this form of political economy. What a lot of people are experiencing, and I think a lot of us are feeling it a lot more, especially over the last handful of years, is a lot of stress, burnout, anxiety, depression, comparing oneself to others, and fear for what is to come. There is a really difficult economic situation taking place right now, and there has been for many years. We are in the beginning of a recession at this point in time, especially post-COVID, and so a lot of people's psychological well-being has been suffering under this system and our current circumstances. We are seeing high rates of mental illness, especially in the United States, and also high suicide rates. It's very clear that psychological well-being of our population as a whole is suffering. I'd like you all to think again, what are some other ways that living in a capitalist society or living in this very individualistic, profit-focused, efficiency-focused kind of political economy could negatively impact our well-being psychologically, physiologically, and so on. I'm sure you all can come up with a lot of examples, but we are actually going to dive into some examples in the following slides as well. This slide here is just a little bit of a personal touch. This is kind of the perspective that I am going to carry out through the rest of this lecture. The idea that despite all of that individualism and profit focus and efficiency focus, Our society is really, really focused on productivity and working hard and working yourself to the bone. And I really do truly believe that a person's productivity is not something that equates to their worth as a person. Um, I find that a very ableist perspective, that whether a person is productive or not, or contributing to society, so to speak, is what determines their worth or their value to the world. And I would just like you all to kind of think about this perspective and think about how possibly it could be harming you to value yourself based on your productivity and things like how much you work or what kind of job you have, how much time you're spending on school, what your grades look like, all of these kinds of perhaps quantifiable things. I really do believe that being a person is all you need to do to be worthy and to be valuable, and that we should maybe kind of try to shake off some of these expectations that are very harmful to us. So health insurance is a huge topic when we're looking at anything economic related to healthcare. We have a couple different kinds of health insurance, and I would love you all to understand this a little bit better. So we have private health insurance and universal health care. Private health insurance is what is more common in the United States. This is the kind of plan most people will be on, or the majority of people are expected to be on anyway. This type of health insurance can be very expensive, which can of course make it inaccessible to a lot of individuals. The monthly payments for private health insurance can be pretty exorbitant. A lot of the time, this type of insurance is also tied to your job, so a lot of people do not pay for this kind of insurance, out of pocket on their own. They might have some kind of healthcare plan related to their employment, which of course can be difficult if one is to lose their employment for any reason, whether they're fired or they quit or they leave for, any number of reasons. You can also lose health insurance in that kind of situation, and so that can be a very difficult situation for a lot of reasons. Private health insurance also, unfortunately, does not guarantee affordability of medical care. Just because you have an insurance plan, even if it's a good insurance plan, you are not guaranteed affordability as far as treatments. You may still have really, really high hospital bills, especially with emergency care or surgical care. So private health insurances are problematic in a lot of ways, but they are very, very common amongst our society and the kind of plans that are available to people. Universal health care, on the contrary, is a healthcare system or structure that is designed for every person in the society or under that government. This type of healthcare is very low cost or sometimes no cost for the patients. So most people, regardless of their income level, are not paying anything extra to be able to access that healthcare. This is usually going to be funded through taxpayer dollars. We also do see from the research that universal healthcare systems have better health and treatment outcomes. So there is less morbidity and mortality amongst the patients who receive care in a universal healthcare setting. Great examples of universal healthcare would be Germany, France, and Italy. There are a lot of other examples as well, but they're kind of doing a really good job of using this kind of system to benefit the people in their population. A little bit more about health insurance here. There is a lot of confusing terminology and information to sift through when you're dealing with anything insurance related. I am not an insurance expert, but I am a medical sociologist, so I spend a lot of time learning about, thinking about, writing about these things. And so a tiny bit of information and advice here for anyone thinking about insurance. It's really important that we have health insurance literacy and numeracy. Literacy means that we understand the words in perhaps our health insurance plan. Numeracy is understanding the numbers that we're dealing with. So a lot of us don't really understand how our insurance works if we have it, and it can be really hard to find an insurance plan that's a good fit for you if you're trying to switch or get on insurance. So there are a lot of terms that you're going to hear, copays, deductibles, premiums, a lot of things like this, and it can be hard to deal with this. It can be very overwhelming at sometimes. So copays are essentially what you pay when you have a health insurance plan when you go to visit a doctor. So you might have a copay for seeing a GP, like a general practitioner, just your typical like family doctor. That would mean that you pay, 20, 25, 30, 40, 50, whatever the amount is. Your insurance will have a set copay that you pay when you go to the doctor. This is often different for general practitioners compared to specialists, compared to urgent care and the emergency room. That'll vary depending on your insurance plan. Deductibles are what you will have as far as the amount you need to pay out of pocket before the insurance starts paying more or sometimes completely covering your care. Deductibles also will vary depending on the insurance plan and how many people are on it, but for example, a person might have like a $5,000 deductible each year. That means they have to pay $5,000 of their own money in addition to paying the insurance fees to have an insurance plan before the insurance kind of kicks in, so to speak. This is going to look very different depending on the plan. Premiums will also look very different depending on the plan, and it can be really, really helpful to work with an insurance broker if you are trying to figure out what kind of insurance plan is best for you, especially if you are looking at private insurance if you don't qualify for other income-based insurance plans, such as through the government. So it's going to be a very individual thing, but kind of sifting through all of those different numbers and those different terms can be really challenging, and there are luckily a lot of good resources online for this kind of thing as well. It's really important to be able to keep yourself healthy, that you are able to access regular medical care, and insurance, unfortunately, is one of those tools that can be pretty necessary in the United States at this point in time to access that medical care in a way that is even close to affordable, and that is even then still not always the case. So we've talked a little bit about how capitalism and this focus on profits and efficiency and productivity over all else can really directly affect how our healthcare system functions. What we do tend to see, especially in the United States, is that medical costs are very, very high in our country, as well as in other capitalist countries too. A lot of the time what the system does to healthcare makes it focus a lot more on profits over people and care. And so what happens for patients is that a lot of the time seeking and receiving medical care is prohibitively expensive. And even for people who have very high incomes, medical costs can be very, very unmanageable. Unfortunately, the United States, we have the highest cost for medical care out of all developed nations on Earth. Out of all nations in the global north and the Western Hemisphere, or the West in general, the U.S. has the highest cost for healthcare compared to everywhere else. And that is very problematic for the people living in this country because it can make accessing care very difficult. A lot of people will delay care to avoid those medical costs. That can have some really negative impacts on our health, right? If you have especially like a critical medical condition and you do not seek care because of that fear of the cost, that can be, of course, leading to a lot of different morbidities, a lot of different health struggles, but that can even in some cases be fatal depending on the condition. And so when we see people delaying care, we tend to see people getting much sicker or much more hurt far before they get that treatment that they need. It tends to be an emergency situation by that point in time, and that's really difficult because we can tell people all we want that you need to go to the doctor when something comes up, but those cost barriers can be really, really challenging and are a huge demotivator for seeking medical care. When it comes to care options, there are a lot of different ways that you can receive medical care, a lot of different settings. There are, of course, hospitals that a lot of us might go to. There are public or private hospitals. A public hospital is funded and managed by the state government. So we don't really have federally managed hospitals in the United States. We do have federal conglomerates of healthcare industry, but a public hospital will be managed by the state government, and a private hospital is going to be funded and managed by an individual or a group. Often this will be like a very wealthy individual or like a small kind of semi-oligarchy of managers who are financially invested in that private hospital. Because of that kind of discrepancy here, we do see that private hospitals will cost a lot more. They'll have higher care costs, and they also actually have higher mortality rates. This is really interesting. Our reading this week actually dove into why this is happening in a lot of detail, so I'm not going to expand on it too much during this lecture, but what we do see here is that private hospitals are really focused on amping up the amount of profits that they're making because they tend to be rather underfunded unless they have investors. And investors don't want to invest in something that is not going to turn a profit. And so they essentially are turning healthcare into a big business that is aimed at putting more money in the pockets of the people in charge, the people who are managing or who kind of own that hospital. And so when we see this profit focus, we also see an efficiency focus where they're trying to get patients in and out as quickly as possible with the highest bill they can. That's not to say that the medical practitioners are choosing this, but that's the structure of the business that is that's really built in that kind of way. And so, of course, you can have amazing medical practitioners, you can have nurses and doctors and all kinds of people in these hospitals that don't agree with that practice or who are really trying to do the best they can to give good care. But when you build an institution in a way that is focused on profit rather than people, you will tend to see lower quality care because of all of those factors that we've been discussing. So we tend to see higher mortality rates at private hospitals compared to public hospitals. When it comes to the way that people seek care, expanding beyond just where we can get medical care, there are healthcare consumers of different kinds. So some of us may be healthcare minimizers, some of us may be healthcare maximizers, and then of course we can also fall kind of in the middle here. Healthcare minimizers are people who will avoid seeking treatment or kind of go to the doctor as infrequently as possible. They may only go in an emergency situation and maybe not even then. That would be at the very, very far end of the spectrum, minimizing as much as possible. And the reasons why a person might avoid going to the doctor or avoid seeking care could be, of course, those financial barriers. But we also have a lot of institutional issues as far as implicit biases, racism, sexism, homophobia, transphobia, and other kinds of discrimination within healthcare settings. That, of course, does not always come from an intentional place or an explicit place of, hatred ideologies or hateful ideologies, but it does happen that a lot of individuals may have medical trauma due to experiencing racism at the doctor's office or ableism at the doctor's office, or perhaps just traumatic medical experiences, very difficult surgeries, very psychologically troubling diagnoses, and other things like that. So a lot of people might be healthcare minimizers for those kinds of reasons. We also have healthcare maximizers, who are people who seek treatment early on and more often. These are the people that are going to tend to go to the doctor for small things when they come up as soon as they happen. Maybe they go to the doctor super frequently, or anytime they have even like a small concern, they go straight to the doctor. And that is really awesome, right? To have that kind of option, to have the ability or the insurance plan or the financial situation or whatever other circumstances lead for that to be possible, that is a really great position for a person to be in. But of course, we do see some people kind of overusing those kinds of resources and perhaps doing so out of a place of anxiety. And so we might have people that are kind of in a discriminatory way called like hypochondriacs. We could consider that an ableist slur, so I would urge you probably not to use that term, but some people will really, really maximize the amount of medical care and treatment that they are accessing. And then, of course, there are a lot of people who fall somewhere in the middle. The average person probably falls somewhere in the middle. So we've got healthcare minimizers, healthcare maximizers, and kind of that Goldilocks in between, where we're not minimizing, we're not maximizing, maybe we're just kind of somewhere in the middle. Taking a little bit of a turn here, I want to talk a little bit about housing under capitalism. It might seem like kind of a jump, but housing is very directly related to a person's well-being and health. And accessing housing under capitalism has become increasingly difficult over the last handful of decades, particularly for people who have disabilities like motor disabilities or mobility disabilities. Accessing accessible housing, or housing that has ramps instead of stairs, or elevators instead of stairs, and things like that, that can be very difficult. So kind of putting a disability studies spin on the discussion here, we see a lot of disabled people really struggling to find independent housing, accessible housing, and affordable housing. There is some legislation in the United States called the Fair Housing Act. This is essentially says that a person, usually a disabled person, can pay to make accommodations or make the building accessible themselves, but landlords are not required to help disabled tenants make those kinds of accommodations. So if a person wants to move into a house that has steps in front and they need a ramp there, that person, per the Fair Housing Act, is allowed to make that adjustment themselves. They can build a ramp themselves with their own money or their own labor, and the landlord cannot penalize them for that, for making changes to the home, but the landlord is not required to make the house accessible or have those accommodations for that disabled tenant. More recently, because of the ADA and the Fair Housing Act, we do see that newly constructed establishments, so things that are being built just from the ground up, completely new, if they have 4 or more units, they are required to be accessible in one way or another, whether that's ramps or elevators or ways that people can get in and out of the building, and especially navigate inside the building. For wheelchair users, we need wide enough hallways, wide enough doorways that a wheelchair can fit through. And so we do see that there are some improvements being made in creating accessible housing and making it at least livable for disabled people, but that doesn't really do a whole lot to help with the affordability aspect. I'm sure a lot of us in this class have been dealing with this in the last handful of years, that housing is very, very, very expensive at this point in time. Disabilities or not, it can be very difficult to find safe and affordable housing. And so when we put this disability spin on it and we look at that population, we see an even more amplified difficulty in this area. Diving a little bit deeper into our disability studies focus here, if we look at public transit and public transportation, the United States is not doing so well in this department. It is very, very limited here, and there are a lot of places where there is no public transportation whatsoever. Only 72% of the public transit that does exist, and that's out of the very limited public transit that we do have in this country. Most of it's going to be kind of in that New England area, like New York, and big cities like San Francisco will have a little bit better public transit. But out of what we do have, less than 3/4 of the public transit options that you could find are going to be accessible to wheelchair users or people with mobility disabilities. With that in mind, there are a lot of people who cannot drive themselves because of their disabilities, and so they do need to rely on some other kind of transportation besides driving themselves or perhaps like walking. We don't have a lot of walkable cities in the United States, and so that's often not an option in the first place. And so a lot of people have to rely on public transit or ride shares or other people for transportation, because it is, again, prohibitively expensive to get an accessible or an adaptive car, particularly for people who are wheelchair users, people who perhaps are paralyzed, like paraplegics. They are going to be $40,000 or more minimum for these kinds of cars. And a lot of the time you kind of have to buy that car off the lot. You can't lease these kinds of cars. They're often specially made. And so a lot of people don't go that route because it is, again, very, very expensive, and there are a lot of reasons that we're going to discuss throughout this class that having that kind of money as a disabled person in the United States is pretty unheard of. A lot of people are not able to save that kind of money, are not able to spend that kind of money, and are not able to access these kinds of resources. And so with our public transit being so inaccessible, with our housing being so inaccessible, and all these things being very limited and very expensive and directly tied to a person's health, right? Having housing and transportation that is reliable, especially to go to doctor's appointments, that can be really, really directly related to a person's economic situation as well as their health. Another important piece of legislation in the United States is the Americans with Disabilities Act, or you'll hear this called the ADA very often. The ADA is legislation, federal legislation, so countrywide or nationwide, that protects disabled people from discrimination in a lot of places, the workplace or employment, education, especially higher education like colleges, medicine, or the healthcare field, as well as housing. The ADA does cover a lot of medical conditions and disabilities, but not all of them. People are always fighting to get different things included in the ADA because there are a lot of conditions that do not qualify a person for disability benefits or protections. But interestingly, if you all are familiar, and you may or may not be, with the civil rights movement of the 1960s, there was also a disability rights movement happening at the same time. And throughout that period of time, we had a lot of really amazing activists working to generate legislation like this and to get this kind of legislation passed to start to protect disabled people from discrimination that was prior to the ADA, totally legal. You could tell someone, I don't want to hire you because you have a disability, and that was completely allowed. And so it took about 30 years after the beginning of the disability rights movement for this legislation to finally pass. You think about the civil rights movement or the feminist movement or the suffrage movement, the women's suffrage movement, a lot of other activist movements got that legislation passed a lot faster. And this really goes to show how our government and our society is still very much not built for disabled people. It's very slow progress to get these rights and to get these privileges and benefits and protections afforded to this population. And there are some, of course, very difficult and negative consequences of how slow this progress is and how infrequently and ineffectively this legislation is enforced even now. A couple of details from the Americans with Disabilities Act, or the ADA, that I'd like to call attention to. When it comes to building access, especially businesses, if a business or an establishment can prove that it's a financial burden to make their space accessible, they are not legally required to change anything. So this could be a building, it could be even a doctor's office that only has stairs, maybe there is no elevator, no ramps outside, and it is completely inaccessible to wheelchair users. If that business can say it's a financial burden for us to make those renovations, we are not going to do it, they can, per the law, be kind of relieved of that responsibility, and they essentially just don't have to make those changes. Of course, it is expensive to renovate a building, but we have to think about what message does it send and who does it hurt and who does it affect when spaces are not accessible. Is it just for this law to be the way that it is? Is it okay that certain businesses can just say it's too much money for us to make this change, we're not going to do it? What are the pros and cons of that kind of situation? Maybe from a business owner's perspective, it's just simply pragmatic. It's just being financially responsible that doing renovations is expensive. And so maybe if they don't expect those renovations to really pay themselves back, then they don't want to make that kind of commitment. But it's also important to remember that 20% of people are disabled. So 1 in 5 customers who can't get into that building or who can't access that establishment can't bring their business to that space either. So I guess there's some things to think about for sure. When it comes to the workplace, looking again at the ADA here, disabled individuals, if they want to sue a workplace for discrimination, they have to get court permission before they can start that lawsuit. This is not something that we see in any other kind of discrimination case. We see, of course, like Title IX cases or discrimination based on things like a person's gender, sexual orientation. We are seeing some changes in legislation right now due to some Supreme Court decisions that are happening recently, but a lot of the time, if a person wanted to, say, sue their workplace for racist discrimination, they don't have to get court permission before they start that process. They can just get a lawyer and go forward with that. So this is kind of a unique case here for disabled Americans. Under the ADA, needing that court permission, that creates a pretty big barrier to seeking justice. If a person experiences workplace discrimination and they want to do something about it, they need to not only have the money for a lawyer independently, but they also have to go through the process of getting court permission before they can sue. And that can be very expensive, very time-consuming, pretty exhausting, pretty overwhelming, and that really creates a lot of difficulties for actually enforcing the ADA and its anti-discrimination legislation. Bringing it back again to a more focused discussion on political economy and disability, if we look at the example of marriage and disability benefits or Social Security, we can see how the system is really, really harmful to this population. There are a lot of different reasons why people get married, but today a lot of people get married just because they simply want to marry the other person. We don't tend to see quite as many just purely economic focused marriages anymore, at least in the United States. And so if a person wants to get married because they love somebody else and that's something that they really want to do, that's, a pretty good reason to get married for a lot of people. So the tricky thing that we run into now with disability and marriage and capitalism is that anyone who's receiving disability benefits or Social Security benefits because of their disability, they often cannot get married and keep their benefits. In 2012, we had some legislation passed that made same-gender marriage legal nationwide, and a lot of people were really excited that we had marriage equality finally. But the disability community is still left behind here, and we actually don't really have marriage equality if we look at disabled people and the kind of inability to get married and keep benefits. The reasons why that happens is because if you marry someone who makes enough money that you are no longer eligible for benefits, which is a very, very small amount of money, you'll lose your benefits because of your partner or your spouse's income. Anybody who is on disability benefits cannot have more than $2,000 in assets or in the bank. So you can't own like a car, a house, you can't own anything that's worth $2,000 or more. So if you have like, a $1,000 guitar, you're halfway up to that limit already. So this is essentially enforced poverty for anybody who is on disability or Social Security benefits. You have a very, very low amount of money that you're allowed to have, a very, very small amount of assets or no assets that you're allowed to have, and it's very limiting. We think about average rent in the United States is over $2,000 for a one-bedroom apartment. Getting a lease, often you have to pay, maybe the first month as a deposit and the first month that you live there. So say you need $4,000 to get a lease, you can't have more than $2,000 if you're on Social Security benefits. So this automatically limits people to often having to live with other people to have a place to live at all. You also can lose your healthcare benefits when you lose Social Security in this instance. If you get married, you might lose your Medicaid. Even if your partner can't afford or your spouse can't afford to provide for both of you, most people on disability benefits are not allowed to work, are not able to work for various reasons, cannot have more than $2,000, cannot have any assets, often cannot live alone, and can even lose their health care if they do get married. So this is a very, very limiting, very problematic kind of system that we have built right now. And a lot of people think that Social Security or disability benefits are really, really good, right? Like being on them is, going to be like a cushy kind of lifestyle, and it really isn't. Typically, it's about $700 per month per person. And so if you think about trying to live off of that, especially living independently and affording medical care or whatever a person might need, if you can't have more than $2,000 to your name, you probably can't live alone, and you've only got $700 coming in every month, it's going to be pretty difficult to survive off of that. Switching gears here to talk about death or dying in a capitalist society. This is a very closely related topic to sociology of medicine or health and illness. Dying is a very heavily medicalized topic in our society, and so I think it's relevant to include here. When it comes to the process of receiving death care or dealing with post-death kinds of arrangements, there are a lot of challenges that we run into because of our system of political economy. So a lot of things leading up to death, what we would call death care, things like an ICU stay or hospice, perhaps live-in nurses or visiting nurses, that can be very, very expensive for a family or an individual. Any kind of care home, nursing home, those are going to be very pricey kinds of treatments or experiences that a person might have in that time leading up to a death. Of course, this is an industry, right? The death care industry is here to make profits as well as to provide those services, but It is a efficiency and profit-focused business, just like every other business under capitalism. Of course, because of that, we will also see within the funeral industry, kind of after we finish up with the death care industry and we're in those kind of end-of-life kind of planning arrangements, there will be, again, some pretty pricey things, some pretty expensive things as far as funeral costs, unfortunately in some cases price gouging on the part of funeral directors. This is not true across the board. Of course, there are a lot of ethical and amazing people out there who are funeral directors, but what we can see is a lot of people who are in a very difficult and vulnerable part of their life, if they're grieving the loss of someone and they're making these funeral plans, that is a time that people are not thinking super rationally and super carefully about their financial decisions, perhaps, and they might pay for things that are unnecessary or just really more expensive than are needed. One big example of this is embalming. Embalming is the process of putting chemicals into the blood vessels of a dead body to preserve that body, often for like a wake or a viewing. And that's something that a lot of funeral homes will kind of push on a family, but embalming is actually not necessary. It is completely optional. It's fairly expensive. It can be like up to $2,000 sometimes. And it is not necessary for the health of the people in the room with the body. You can do a wake with an unembalmed body, and that is completely fine, completely safe, unless that person died from, a very contagious disease or something like that. But there are a lot of examples of things that are done within the funeral home that are not necessarily necessary, but they can be very expensive. We also, of course, see the privatization of death care and all these different practices within the funeral industry. We tend to see death care professionals such as ICU workers or hospice workers, funeral care workers, and things like that, replacing family in death care. And I know we're very squeamish about death in the United States. A lot of people would be horrified at the idea of being a part of the death care for a loved one, and that's totally okay. If that's something that you would not be comfortable with, dealing with the death of a family member or taking care of their body or something like that, you absolutely don't have to. We can outsource that care to death care professionals. But that's not how it always was. It's only been about 100 to 150 years in the United States that we really did use death care professionals rather than taking care of these things within the family. And that privatization of death care, just like privatization of really any kind of service or good, does lead to increased costs and, again, that kind of business focus where efficiency, productivity, and profits are really one of the biggest reasons why the business continues. Finally, just like, again, a lot of things that we see happening under capitalism and this form of political economy, we see a lot of environmental destruction related to death care and our funeral industry. Embalming, like I mentioned before, it uses chemicals to preserve a body, and those chemicals are actually very, very dangerous to people. You have to wear basically a full-on hazmat suit if you are working in that industry and doing embalming. You really don't want to come in contact with those chemicals. But what happens when a person has been embalmed and buried, eventually those chemicals do end up in the groundwater, they do end up in the surrounding soil, and beyond just the embalming alone, there are a lot of chemicals and materials used in caskets and burial that are very harmful to the earth. And when we see, or when we look at cremation, the process of cremation, that creates a lot of greenhouse gases and leads to further issues with our environment as far as climate change due to the emissions of cremation. So a lot of people are looking into more kind of green burial or alternative burial practices because of these issues and because of the cost. Because it is an industry, the death care industry, the funeral industry. It does a lot of really amazing, really important things, but it also can be very expensive, sometimes kind of predatory with those things like price gouging, and the effect on the environment and the world that we live in can be pretty negative and something that we might want to think about trying to alleviate or avoid as we move forward with these practices. That was a quick summary of what healthcare and the medical industry in the United States and other countries can look like when we're looking at political economy or capitalism. There's a lot more that we could cover, but for the sake of time, I would really urge you to focus on the readings this week as well for more information and more detail here. A quick summary of what we went over in this lecture. We talked about how for-profit healthcare systems have worse healthcare outcomes than universal healthcare systems do. We see a lot of physical, physiological, and psychological well-being being harmed by our current systems and just all the stresses and barriers that people are facing under these systems. We also know that health insurance can be complicated and difficult to understand, but there are a lot of resources that can make this easier. You can always just Google about it and use those fact-checking skills to try to deduce what is going to be the best kind of plan for you and your situation. Of course, we also know that marginalized groups are facing the brunt of the hardships generated by capitalism, particularly disabled individuals, but anybody who is low socioeconomic status and people whose identities might overlap with that low SES kind of identity. We see a lot of Black, Indigenous, and people of color struggling with poverty, a lot of disabled people, a lot of women, a lot of people across the board in our nation struggling with poverty and these kinds of hardships related to healthcare and the economy. Finally, we know that disability justice efforts in the United States have a long way to go. There are a lot of problems with marriage equality not being really something that exists quite yet, with inaccessible buildings, with unaffordable housing, difficulties with transportation. There are a lot of challenges that we are seeing in our country because of our former political economy. And I would urge you to think about, what are some alternatives to these issues? What are some potential solutions to these issues and alternatives to these systems that are creating those issues? We have a lot of examples of other countries that are using universal healthcare systems, and they're seeing really, really beneficial healthcare outcomes. They're seeing a lot more well-being increasing for their populations, in contrast to what we're seeing here in the United States, which is quite the opposite. They're also just seeing overall higher quality of life for places that are more accepting toward their disabled population, more accommodating, and so on and so forth. So thank you for being here for this week, and I will see you all next week for another lecture.